Okay, good morning, everyone. Looks like we have somewhat of a quorum with about 16 people on at this time, and it's nice to see some new names as well that we haven't seen before. So thanks for joining us for our new series. Very belated Happy New Year to everyone. Again, we're continuing with the theme of health equity and cardiovascular risk. These are some general reminders that will be applicable throughout this series. I know many of you have participated before, but when you are discussing your cases, please be careful not to mention any private health information. You can use initials for the patient's name, etc., but do not disclose any private health information. If you have any technical or other concerns, here's the list of contacts, Rick with IT support, Andy, who is our clinic coordinator, and along with Claire, and I will be facilitating. Some information about cardio. It's hard to believe we have been around for 7 years now. It's an initiative of med schools across the state and to disseminate best practices for management of cardiovascular risk. So this morning I'll be facilitating. This is our list of experts who will be joining periodically depending upon the topic and the case studies that are going to be presented. And a lot of our experts will be presenting didactic sessions as well, including this morning when Adam will be presenting. Some disclosure statements. These have not changed, I don't think, recently. I don't have any disclosures for this series, but you can look those up. And here we have a representation of the diversity of geographic locations from across the state. As you can see, we have quite a range of folks from Southeast Ohio, Northeast Ohio, and elsewhere as well. So this is a list of sites. So ECHO is a community, and we do expect everyone to be able to interact with each other. We often don't have time for that, but we definitely encourage you to interact with your colleagues, and they'll be near the end of the series. That's when people become more interactive with each other. So today I'll be facilitating as usual, and Adam will be presenting some foundational information on health equity. I think that'll be helpful throughout the entire series. So turning things to you, Adam, take it away.
Thanks so much, Gotham. Really nice to see everyone this morning. Also fun to see some familiar faces on here. It's a nice surprise. I'm going to give an overview of the concept of health equity and a few small examples. The presentation today, I think I've given a version of this together with Dr. Joseph and Dr. Adebambo, so they definitely have made contributions here that should be recognized. My role is I'm a sociologist in the Population Health and Equity Research Institute at Metro Health. The objectives today are pretty straightforward. We want to give a definition of health equity as it pertains to healthcare delivery in the US, give some examples of which specific subpopulations or some specific subpopulations and how they're disadvantaged in health and healthcare, particularly around cardiovascular risk. And then overview very sort of high level examples of how social determinants can be leveraged to improve health in clinical settings. This question, there's no straightforward answer, but I think this summary that I've presented previously with Dr. Adebambo is useful. The idea that health equity is this state where everyone has a fair and just opportunity to attain their highest level of health. So I think the focus there is on the phrase fair and just. So achieving fair and just really means that we need to overcome historical injustices and contemporary injustices and think about the barriers and obstacles to health and healthcare. Those can be economic or social or behavioral. There can be lots of layers of barriers to health. And we really need to eliminate those health disparities that are preventable. And I'm going to give some examples of that. But if health disparity is part of our definition of health equity, then we need to talk a little bit about health disparity. I think the healthy people definition that's been running for about 3 decades now is useful. Health disparities are a particular type of health difference that is linked with social, economic, or environmental disadvantage. But it's also important to think about it in the way that health disparities adversely affect groups of people who have experienced obstacles to health. So typically what this means is that like groups of people who have some other set of social vulnerabilities tend to be more vulnerable to health disparities. Other distinction I think is really critically important from an introductory standpoint is the distinction between a health disparity and a health care disparity. And here I've listed insurance coverage, access and use in care, and quality of care as care disparities. Another way of phrasing this is like healthcare disparity can easily be thought of as the things that happen in the building in healthcare, right? The stuff that happens when somebody's in the hospital or the emergency room or the clinic or the ambulatory center or the rehab. Those care disparities. Certainly care happens not only in those settings, but it feels particularly egregious when there are those differences in the systems of care that we're providing and not just in differences that are happening out in the community. This is a data slide from Adam Vaughn, and I think it's one of the better depictions of what racial disparities look like over the past 20 years in the United States in cardiovascular outcomes. And what we see is a massive gap whereby African American or Black Americans for more than 2 decades have experienced a massively higher rate of death to all cardiovascular causes than other racial and ethnic groups. There are other couple of other things to note here is that that gap occurs both among younger adults or midlife adults and older adults. So the top versus the bottom figures. And then we also see a disturbing trend here where like pretty much all the lines are going up since 2010. Now, some epidemiologists attribute this a little bit to increased survival and improvements in cancer care. So that like we're doing so much better in helping people survive from some diseases that we're now dying from cardiovascular diseases more, but it's also increases in rates of disease like diabetes and overweight and obesity, just like all of these things contributing together to general increases in the rate of cardiovascular disease mortality over the last 10 years. So it's really important that we remember that health equity benefits everyone and health disparities are avoidable. I think if there are two things from the beginning of this talk that you should remember, health disparities are avoidable, health equity benefits everyone. I think this statement here is worth reading, which is that every person who dies young is avoidably disabled or is unable to function at their optimal level represents not only a personal and family tragedy, but also impoverishes our communities and our country. We're all deprived of the creativity, contributions, and participation that result from disparities in health status. So we can trace a lot of the differences that manifest as health disparities to processes of structural racism, in particular racial bias that continue to exist in institutions and across society. Um, and this involves a cumulative and compounding effect of a wide array of social factors. And I think my next slide is really nice here. So this is from Joshua Joseph at Ohio State and his colleagues. And I think they do a nice job of really linking a cascade of contributors to disparate health outcomes, particularly cardiovascular outcomes. And I think he, in this figure, really describes sort of two parallel sets of influences, historical influences. And what I like about that is that he's really showing here that science and medicine also own the history of structural inequality. So, and in the top box on the left there, he talks about the history and science of the theory of eugenics, which defined certain racial and ethnic and cultural groups as biologically inferior, which we know is not true. He talks about here the closure of medical schools about 100 years ago, There was a sort of systematic change in medical education in the United States a little over 100 years ago that resulted in most of the medical schools that trained most Black physicians to close. The and then I think most of us are also familiar with the history of situations like the Tuskegee syphilis study, whereby African American men were experimented on without their consent, but that's one of many examples. So that the downstream effects of those things include a decrease in trust, um, ongoing bias against patients from different backgrounds, and then persistent barriers in language communication. And these manifest in care access and low health literacy, which in turn lead to a lot of the things that we see clinically. We see higher rates of disease, higher rates of important cardiovascular risk factors, which in turn lead to disparate outcomes. And then in parallel, though, to these sort of medical scientific contributors, we also see really clear structural differences in our society that are not just in medicine and science, that happen in our neighborhoods and schools and open spaces. Uh, So a number of years ago, I worked on this project where we did a bunch of qualitative interviews with African American men and their care partners here in Cleveland. These were folks who had all had a stroke before the age of 55. So they're young Black men who had had strokes. And what we wanted to do was talk to them about the challenges that they had. If you're not aware, younger Black men who have had a stroke are somewhere 8 to 10 times more likely than other men who've had a stroke to have a second stroke, to have a recurrent stroke. And so one of the thoughts is that maybe there are some barriers to risk factor reduction there. And so what we did is we talked to these men about, well, what are the things that make it hard to adhere to something like the Life Simple 7, which I know we're generally talking about the Simple 8 these days. But back then when we wrote the paper, we called it the Simple 7. And we heard some interesting things. Here's a little table. You can't read any of it, so I just made a call out. But basically, we looked at all of those areas of risk factor reduction, and we heard from our participants about very clear barriers. And I like to read this particular quote. I focus on what's going on with African American men, and one of the reasons why we're having so much stress, I think, a lot of stuff is dealing with stress and social issues. When you start talking about it towards African American men, the stress got to be at least 75 to 80% of why we even had a stroke. So I think our participants had a pretty clear view of the barriers, like practical barriers, but then these general barriers about sort of community stressors. When we look at Northeast Ohio, a lot of my projects focus on neighborhood. This pattern repeats itself in most of the urban areas across the state of Ohio. But what we see massive gaps in cardiovascular outcomes and all-cause outcomes. So here, we're showing just life expectancy at the census tract level in Northeast Ohio. And what we see is a gap in life expectancy between the longest living neighborhoods and the expectancy that's the shortest in Ohio neighborhoods of approximately 20 years, um, in neighborhoods that are just a few miles apart. But we also see that that gap is powerfully associated here. The measure that's labeled LADI is the Localized Area Deprivation Index, which is a measure of the socioeconomic position of neighborhoods that spans 15 indicators like median household income, rent, employment, whether families are single parent or married households, um, levels of education, and whether people own vehicles, and lots of indicators of socioeconomic position. And so what we see is a clear patterning whereby socioeconomic position seems to be the primary driver of these neighborhood level differences. If we dive deeper on this, so this is a cohort in one of my ongoing studies of 500,000 primary care patients here in Northeast Ohio. And we looked at across every 5 years of age in this cohort. And we, instead of using a CDC death certificate model for estimating life expectancy, this is an observed life expectancy estimate using electronic health record data linked to the Ohio deaths data in this cohort. And so you can see the green wedges versus the blue wedges on, again, this measure of socioeconomic position called the area deprivation index. And you can see that the green wedges are really shifted left in pretty much all cohorts, except when you get to the oldest folks over the age of 95, where there's a compression in life expectancy because nobody lives very long when they reach the age of 95. But you can see these massive, massive gaps, even initiating as early as the age of 40. Um, and you see the gap is a little bit wider for men than women. But the other thing to notice here is it sort of looks like you can see in like the statistical term with this, the blue curves are a little bit more kurtotic, which another way of thinking about that is like it's almost like somebody took and stepped on the curve and smushed it down and made it flat for the green curves. And that indicates increased variability so that we have like a compression of variability for high socioeconomic position, people in high socioeconomic position neighborhoods. Like it's more uniform and more predictable how long most folks will live. But for everyone else, there's so much more variation. And a lot of that variation is explained by socioeconomic position. So this and other work have really highlighted the power of neighborhood factors for health. And so what we know is that people who live in neighborhoods that have inferior places for shopping, there are lack of places to exercise, there is a lack of open green space, a lack of natural beauty. There can be tremendous vacant housing problems in the city of Cleveland. Right now, there are over 31,000 vacant parcels. Um, and if you think about that, there are only 110,000 rental properties in the city of Cleveland. So we have for every property that we're renting, we have 0.3 that are vacant. This is purely vacant land where there's no property anymore existing. There can also be issues of traffic, crime, and safety. And if we think about it, there's a lot of evidence on how these things enter into our bodies and manifest as cardiovascular risk. And this can be like, well, if you don't have a neighborhood that's safe to walk in, then you're not going to be able to exercise as well. Or if you don't have, similarly, if you don't have access to recreational facilities, but then also physical environments can be toxic. We can have air pollution and other pollutants in our communities. The other thing I like to highlight is a bit of work that my colleagues and I have been involved in for about 15 years now, where we've looked at the idea that these situations that impact particularly urban neighborhoods in Ohio are not things that happen sort of randomly or by chance, but they happen via historical processes of racial discrimination. And so here we provide an example of how the Homeowners Loan Corporation in the 1930s, which was an agency of the United States federal government, produced maps that color-coded neighborhoods of most cities in the United States of America, including all of the cities in Ohio. Um, and what happened was that the neighborhoods that were shaded red on those maps were denied home loans for decades. But particularly at this critical period in the history of the United States, which is really sort of like the nation's attempt to recover from the Great Depression. Uh, and so no one in a neighborhood that was redline would be given a loan, regardless of their race or ethnicity. There are some great anecdotes out of Cleveland where a couple of the banks that existed in redline neighborhoods, wanted to get a loan to rebuild the bank or renovate the bank, and a bank in a redlined neighborhood couldn't get a loan from another bank. So they actually had to move out of that neighborhood to a suburban neighborhood. And so it's also symbolic of the flight of capital that happened when we denied capital to neighborhoods based upon racial grounds. So in our own work, we wrote this paper that was published in Du Bois Review, I think last year, where we found that if there was an Ohio neighborhood where any African American person lived, that neighborhood was 45 times higher, like 45 times more likely to be redlined. So this was like a process of racial discrimination that was specifically traceable to actions of a government agency that really continues to be manifest in our neighborhoods today. And what we can see is, so this is just an example of the redlining map from the city of Cleveland or Greater Cleveland in 1940. Here's a note on that map that's important to read. About 2 years ago, a strong effort began to decrease the colored occupancy of this area and has resulted in the moving of 33 families, some of whom were moved at the city's expense. In each case, the removal of a colored family caused the occupancy of a white family in this neighborhood. There is also a tendency toward improvement in the physical appearance of the community during this same period. So this is a particularly egregious example of not just homelanding, but actually displacement of Black families from neighborhoods in Northeast Ohio. The the other sort of shocking thing is that this redlining map looks a lot like the contemporary map that I showed of life expectancy for our region, and that the same neighborhoods that were redlined in the 1930s are the same neighborhoods that are experiencing the highest rates of cardiovascular death and all-cause death in 2017. Oh, and I have a picture of that. So here's the life expectancy map next to the redlining map. So with this sort of grim introduction and this like structural basis of inequality in Ohio, I think it's also really important to give this brief anecdote on the history of improvement in cardiovascular health in particular. And so here's a nice like 30-year depiction of sex differences and cardiovascular mortality in the United States. And what you can see is that in the mid 80s, there emerged in a widening disparity in cardiovascular death between men and women. And one of the reasons for this is that it was traceable to women presenting differently with signs of cardiovascular morbidity than men. And a lot of the research on primary and secondary prevention of cardiovascular disease had been developed only on men. And when this gap emerged, the epidemiology, population health, and medical communities began to realize, oh, women are dying of cardiovascular disease at a rate much higher than men. We need to do something about this. And so then over the course of the next 2 decades, there was a burst of research on how to better care for, detect, and prevent cardiovascular health problems among women. And coming into the year 2011, that gap had been fully eliminated. And now what we see is a reversal. If you remember the slide that I showed very early, what we see is now a widening gap whereby men are once again sort of back like 1979. Men are back and experience more cardiovascular morbidity than women. So social change and medical change can be linked, and improvement is certainly possible. Like health equity is achievable. The World Health Organization, I think, provides some of the better recommendations for improving health equity, and they tend to be very, very simple. The first one is to improve conditions of daily living. So if we think about how people live on a day-to-day basis, it's typically straightforward to see that persons in low socioeconomic position neighborhoods live lives that are more difficult and characterized by social and health adversity. The second is to tackle unequal distribution of power, money, and resources. So that we know that on a national basis, and even within the United States and within states in the United States, such as Ohio, that counties characterized by higher rates of inequality um, show the greatest gaps in cardiovascular outcomes. And then it's really important just to measure and understand the problem so that ongoing surveillance of differences is really important because then we won't know if we're monitoring and achieving equity. And then maybe most importantly is to monitor how we're doing in our efforts to improve. The, so I think these are questions that I will leave you with that I hope you reflect on regularly. I certainly do. The first is how can learning about health equity throughout this ECHO series and in other ways influence the way you'll provide healthcare today and in the future? And then in what ways, this is my favorite question, in what ways are you already working to be sensitive and to do extra things for the needs of diverse and vulnerable patients? And in some of my other teaching in faculty development, one of my favorite examples here is to think about all those forms that you all work on. So, like every doctor is filling out forms. There's so many forms, right? Not just the electronic health record clinical forms. When patients have all these forms, I took my son to the doctor this week and he needed a form so he could get back into school. Right. Like had to have a signature so that they would allow him in the door. The um, but one notable example is like the Home Energy Assistance Program or HEAP form. I would bet that every physician here has filled out, many, many of these. And so this is a way that you're already acting to address a social determinant of health for your patients that could be critical for improving the conditions of their daily life if they can't afford their heat or their water or their electricity, if they can't afford their utilities. By filling out that form, you can make really important changes in people's lives. So, like, yes, it's some pain to fill out all those forms. On the other hand, like sometimes that form might be one of the most influential things that you do in your daily work as a clinician. And I think that's all I have. I'm happy to hear some discussion or take some questions. So thank you all for listening. It's really exciting to join you for this Echo series.
Thanks, Adam. Great discussion as always. I had a question. I mean, some of your slides really make you reflect about certain things, especially the compression of life expectancy, which I actually think as almost hopeful. You know, if we could get everybody to a certain point, then hey, we've kind of achieved something. But I wanted to ask you, most of my patients, the vast majority are African American, and that includes some who are physicians, professors at Case, a very small percentage, obviously. My impression is, these are folks that will send you your My Chart agenda for the visit and inform me of things I don't know before I actually get there. That, there's a socioeconomic threshold above which, health equity is achieved. Is that true when we deal with income and education? Does race become really negligibly important at a certain point, which I think of as hopeful as well? So,
Wow, this is an awesome question. So I would say like the best answer I have here is somewhat. So and I wish you really motivated me. I to finish this work. I have another project that's ongoing now. It's called the Digital Twin Neighborhood Project, and we're really diving into differences in cardiovascular risk in midlife. So really looking very, very carefully at adults who are between the age of 40 and 55, where we see that biggest gap in life expectancy in the figure that I showed. Um, and here's also where we tend to see really big gaps in socioeconomic position and education level. But one of the really interesting things that we found in data, and I'm sorry I don't have this figure, we literally just viewed it on our team yesterday. One of the interesting things that we found in Northeast Ohio is that among African Americans, both men and women in the 40 to 55-year-old age cohort who live in higher socioeconomic position neighborhoods, what we found was no evidence of cardiovascular disease disparity and risk. So in that cohort, the they had essentially the same blood pressure, the same lipids, the same rate of diabetes as folks in other neighborhoods. And we could go down to like the census block group, like really small areas of Northeast Ohio. And also our data on that project contains virtually everybody. We have 80% of all the people in all the neighborhoods in this particular EHR study. So I'm pretty happy with that result. So, but what I would say is, despite that, there is this very disturbing trend where the converse of this sort of is also true, whereby persons of all races and ethnicities who live in low socioeconomic position neighborhoods in midlife have elevated levels of cardiovascular risk. So that effect of income, education, and other factors, particularly neighborhood factors, doesn't seem to discriminate. While persons who are white may not experience the same levels of interactional discrimination as other groups, the wear and tear of daily chronic stress of living in a low socioeconomic position neighborhood, what we see is similar elevated levels of blood cholesterol, prediabetes, hypertension in those low socioeconomic position neighborhoods across all groups.
All right. Well, thank you guys. Turning back things to Andy just for a moment or two. We'll give you a few minutes back.
We'd like to invite you all to attend the cardio webinar this February 28th at noon. You can register through the QR code or through the cardio website. You can access all present and past echo recordings on our website as well through these two links. And just as a reminder, you should have received a post-clinic survey. Please complete that by tomorrow evening. Also, if you have not submitted case studies or other forms, please do so as soon as possible so we can release a schedule so everyone knows when they'll be presenting. If you have any questions, please feel free to email me.
Okay, thanks everyone. We'll give you about 5 minutes back and hopefully we'll see you all next week. Take care.